So who or what are stakeholders? Just to start off, so we're on the same page, I think this is a good definition from seminal work. So it's just the parties that are affected or will or could affect a given group's strategy. So how you might want to think of stakeholders in terms of the goals and objectives of your collaborative team, I would suggest that you could think of anyone that's affected by the conditions that you're seeking to change and or the strategies that you're pursuing. Now, that obviously is a very large population when you think about not only people that are suffering from opioid addiction, but their families, caregivers, and so on. That's a large population. Then we add to that anyone that can influence either positively or negatively your collective ability to make that change happen. So if you think about the people that can influence, you're talking about people that bring knowledge to bear, people or organizations, by the way, people or organizations that have financial or other tangible resources, those that might have political influence, or those that might have pathways to target populations that you're interested in. And the process of identifying stakeholders is not there's no kind of magic formula. It's just being able to broadly consider these different categories and I'm going to be interested to hear from Tony and Elaine, like sort of the process they use to identify some of these key stakeholders, but to be strategic about it, not just to involve the obvious ones, but to think carefully about those that could really help make a difference in your efforts. Why stakeholders matter? I think there's a couple key reasons that we're here to talk about it. One is that the nature of the issues that we face in our communities are increasingly what we call wicked problems. They're highly interconnected, and making a change on one aspect of the problem might cause new problems somewhere else, and we call those wicked problems. And because of that, no one entity can kind of easily fix it. If so, it's kind of a simple technical problem that we can all fix. But obviously that's not why we're here. We're here to deal with the wicked problem of the opioid epidemic. Also, just the fragmented nature of organizations that have a piece of these problems. And by fragmented, I talk about fragmented jurisdictions. So just thinking of all the different governmental jurisdictions, for example, there's state agencies, there's county agencies, local governments, and so on. Layer on top of that the fact that there are public and private organizations that kind of have a piece of this, and then you got different kind of functional sectors of work. We're talking about law enforcement, education, healthcare, and other types of nonprofit communities. So all these different organizations kind of have a piece of it, and they don't necessarily naturally work together. And so that's why it's really important to kind of strategically think about who these stakeholders are and how they might be engaged in the work. And then the last one is we often think about engaging stakeholders because our own, in particular, the organizations that we come from are strapped for time and for money. And even if we could do major work on our own to solve a problem, we may not have the resources or to do that. And so as we partner with other organizations that have similar goals, we can then expand our ability to address the problem. And so the bottom line here is that ongoing stakeholder engagement and collaboration is essential for tackling wicked problems. It's not a luxury, it's a must-have if we're going to make any progress on wicked problems like opioid epidemic. The last slide I just want to show is it can kind of be overwhelming to think about engaging the wide range of stakeholders that we understand are out there. And so I think one kind of useful framework for thinking about the engagement element is to realize that there are different kinds of engagement. And the most intense engagement are these partnerships and collaboration. And so not all the stakeholders need to be engaged at that level. And so as you are leading, playing a leadership role in a collaborative effort, you can identify which ones need to be with you kind of for the long haul as a partner versus lower levels of engagement that can involve a lot more people. So some stakeholders you may just need to involve here and there. Some you may just need to consult with occasionally, which is literally just asking for their input, asking for their feedback. And some you may just need to inform. And informing is a form of engagement. And of course, we can send information out to lots and lots of people, and that doesn't require near as much effort. And so as you're kind of strategically thinking about engaging stakeholders, I think that's a useful way to approach and kind of almost think in buckets of who do we need to keep informed, who might we need to check in with occasionally, who might we need to involve in some sort of meaningful way over time, and who needs to be a partner, like a collaborative partner that we need to have at the table working arm in arm with us. And as you think about it in that way, I think it can kind of help make that more manageable. All right, so now I need to unshare. And just with that simple framing, I'm going to turn the time over. We'll start with Melaine and have her share some of her experiences in identifying and most importantly, how they have gone about engaging stakeholders and some of the lessons learned. And then we'll turn to Tony and go into a discussion after that. Melaine?
Hi, good morning, everybody. So I feel like I bring kind of a unique perspective to this, speaking from the opioid treatment program side of things. We're kind of like the redheaded stepchild of treatment. Not only are we struggling to fight the stigma of addiction, but we also have to fight the stigma of medication-assisted treatment. So for us, engaging our stakeholders and identifying stakeholders took a lot of determination and dedication to get to the table. Oftentimes, people don't think about inviting opioid treatment programs to these types of conversations, even though medication-assisted treatment is the most evidence-based treatment for opioid use disorder. So it makes sense for us to be there, but oftentimes it just doesn't happen. So we spent a lot of time doing a lot of education. We had an open house. We could invite people into our office. We do multiple lunch and learns. We've done lunch and learns with DSS, with our probation officers, with any police officers that would attend, with our local emergency room, the OB, anybody that will listen to us, basically we will talk to. We also like to let patients tell their stories. You know, we can educate all day long on what we do and how we do it and how effective it is, but at the end of the day, when you hear someone tell their story, that's much, much more powerful and makes a much bigger impact than anything, you know, I can tell you about treatment. So we also like to do that when we're given an opportunity to. It also took a lot of thinking outside the box. We started attending a multidisciplinary team meeting at a senior center. Somehow randomly got invited to the table at this particular meeting, and it ended up creating relationships with hospice and the CAT program, which led us to more educational opportunities, and lots of cross referrals has came from that collaboration. Lots of community coalitions, building relationships, being involved in community events. Project Lazarus is very big here, so we've been on all of their youth coalitions, their substance abuse coalitions, working with our local Daymark, which is a mental health agency, going to any kind of like health fairs and things of that nature, setting up a table where, you know, we could tell people who we are and what we do and put names and faces instead of just being known as, you know, the clinic, as they say. We were also fortunate enough to invite Attorney General Josh Stein and his wife to our clinic, and Senator Deanna Ballard. We had them both in for a tour had lunch, showed them, it's very interesting when people actually come into our building and see how a patient comes in and goes through their intake process. That kind of makes medication assisted treatment real. So that's been very helpful for us. And it's just been, being very committed and, sticking to building these relationships and continuing to go to the many meetings that are, held month over month, and just, being available when someone calls and taking the time to educate anybody that will listen, basically.
Very good. Sounds like you've been very creative. And just a quick question, then we'll go to for me, and if there's any other questions, they can jump in. But how has your team been able to identify kind of some of these creative ways to reach different stakeholder groups?
I think the best is that is a lot of trial and error. I remember back in 2012 when I first started, we would get case plans from DSS that would say, in order for someone to get their kids back, they had to be out of treatment. We were very fortunate to be able to have a discussion with them and explain the benefits of treatment. And, now we're seeing case plans where treatment is a part of them getting their kids back. So I think it's just, the persistence and talking to anybody that would listen. And then, once you get in the door with somebody, they're like, oh, well, you need to talk to so-and-so and you need to talk to so-and-so. Luckily for us, we're in a rural community. So, everybody knows your mama, your daddy, your brother, your sister. Somebody knows somebody that knows somebody. So a lot of it was just word of mouth, hey, I just talked to so-and-so about this, you need to talk to them. So it was a lot of that networking type thing, kind of being a social butterfly, for lack of a better word.
Mm-hmm. And I'm just curious, Melaine, if it sounds like a lot of those touch points have been mostly on kind of the informing, if thinking about those levels, sharing information and to kind of empower people to be able to act. But have some of those touch points led to kind of deeper engagement? Does that question make sense? Like if some of those people have been able to really join the partnership or engage in deeper ways?
Yeah, absolutely. Part of what we've been doing with the COPE team has allowed us to delve further and not just, looking at the treatment side, but being able to work with our other partners on the transportation piece, on housing, on food insecurity, on all the other aspects that touch addiction, but not specific to treatment. So it's been very beneficial to build those relationships. Also, partnerships with Project Lazarus has helped us with, some grant funding that we were able to get in the past, some potential grant funding that we're working on now. So yes, very much so.
Are there any other questions for Melaine at this point? Want to jump in, Brendan?
Yeah, hey, Melaine, thanks for the overview. And I apologize if I missed it, but do you guys have any faith-based involvement? Do you have any religious groups that you connect with?
We do. We actually have it's called Faith Health. It's through our local hospital, and they've been wonderful to work with. We've been able, dental care is very, one of the major barriers for patients that we have in treatment. A lot of times they'll have, a slip back to use because of unmet dental needs. They don't have dental insurance. We've been able to connect them with Faith Health, and they've been able to hook them up with a dentist that does significantly decrease pricing and been able to pay for it. So yes, we're also looking at ways to work with the faith community on transportation barriers. Some of the church vans and stuff, being able to take people to doctor's appointments and to bring them to treatment and so forth, and so things like that. But yes, and we're also working on another project with Project Lazarus through a HRSA grant. We're working on having a faith forum where we're going to have multiple, faith-based centers together, so they can all get their information and we can all share information in that forum also.
Thanks.
Very good. Why don't we go ahead and turn to Tony and hear some of his experience in Forsyth County. And again, you can feel free to jump in with questions and we'll kind of go just a conversation after that. Tony?
So thank you. So we've had a unique experience specifically with our opioid task force. So I'm gonna give you a little spoiler alert because you might hear this story again this afternoon in part of the forum sessions. But so in Forsyth County specifically, we had the initial problems. We had a lot of stakeholders up front and fast. Looking back in late 2016, early 2017, we had a pretty significant community outcry surrounding substance use and opioid overdose deaths around that time due to the spike in data. Now, this not to say that this wasn't occurring beforehand to a maximum problem. It was occurring, and we in the county, local governments, first responders, hospital systems, we're all kind of working within our respective fields at that time and trying to adjust and adapt to it and be creative. But collectively, there was nothing out there community-wide to make some type of effort to curb this problem. So at that time, there was a community outcry. We were just starting to get into harm reduction education within the county. Our EMS, our public health departments, and our law enforcement were starting to synergize, and we started to have specialized teams develop. So based on that, I like to call it the big bang moment with everybody kind of saying, hey, we need to do something. We got everybody together. We did media outreach. We did social media outreach. And we said, hey, if you have an interest in this, come to Green Street Church. We want to provide you an opportunity to express your concerns. Let us know as a community who you are and how you can help. And so long story short, this meeting happened at Green Street Church. We had over, at that time, 60 organizations represented: law enforcement, judges, harm reduction, hospital systems, local policymakers, local administrators from local government, counties. We had folks from outside the county, sheriff's office. I mean, too many named folks that were affected by opioid overdose, people that were in recovery, people that were actively using. So the discussion, basically a discussion was had. It kicked off with some harm reduction education, but really turned into a question and answer forum. This was an opportunity for us to say, okay, we're going to have an opioid, we're going to join it, we're going to develop a task force, come to public health on March 2017, we're going to hold this meeting. So this was our first initial kickoff meeting for our opioid task force, and it was huge. I think we exceeded our building capacity or meeting room capacity. Don't tell the fire marshal on that to this day, but we exceeded it. We had a lot of people in the room. It was packed to the gills. So we had the initial problem stakeholder engagement. We had the passion, but we had a whole lot of folks to try to herd cats, if you will, and say, oh my God, what are we going to do with all these people? How are we going to make an impact? How are we going to move the needle? What do we do next? And to be honest with you, it took a couple months to really take some organization and put this together so we can start, number one, have an official task force, but to have this task force actually make an impact in our community. So we started the task force. We said, okay, we're going to hold these, since we had so many people, we're going to hold our task force meetings on a quarterly basis. But we know as a group, this huge, with at least 100 people showing up here on site, we're not going to get anything accomplished. So from there, we started to develop sub-working groups amongst our stakeholders. I think our first 4 sub-working groups were first responder group, schools, judges, and if I remember, treatment centers. And their job initially was just to start talking and start kind of looking at what they can start working on in their respective fields and start moving that needle. That obviously wasn't good enough. So part of stakeholder engagement, looking who we should have on these teams, as these groups were meeting, they started developing, this is who else we need, or maybe we need a subgroup over here. So we ended up expanding based on this conversations to 9 different working groups. Our first responder group, just as an example, we ended up moving law enforcement into the judges group. We ended up calling law enforcement, and their projects were like post plea, drug court, a whole host of things. But what I'm trying to get across is we end up having all these subgroups to work on these projects. Even the school government project that we had a sub-work and project management group specifically to help drive the task force. So I say all that. Basically, what we turned it into is quarterly. These sub working groups report out to the task force as a whole every quarter. And the graphic that you showed, basically, it said that had the to inform. You had more stakeholders, but I mean that's right in line with what we were doing. And then to actually put some action in place, you have less stakeholders, and that's actually how it turned out for us. So.
Yeah, I just have a couple clarifying questions. At the front end, when the task force came together, was that literally anyone that wanted to be a part of it?
Yes, anyone that wanted to be a part of it, anyone that had a passion to do this work, we said, come on in.
So no
show us where you
selection
can help.
process. And then as the working groups got formed and actually going out on their own and doing stuff, did they have any kind of facilitator or chair person that kind of ran the meetings? Like, how did that organization? Because this sounds like a very organic process, and I'm just curious how it settled into sort of organization.
Yeah, so all that was part of discussion. So a couple of things we had to, it was obviously in line with what we're talking about, how to look at as we're developing these subgroups. Number one, who is the right chairperson for this group? Should the group deciding on their own? Do we have the right people in that group? They're going to have the right time commitment. So we had open and honest conversations with folks, or calling folks, hey, we'd love for you to sit on this committee. Please, do you have the time commitment to do that? Are you willing to do that? So we reached out to them first. We just didn't say, congratulations, you're on this committee, do some more. Some of the groups kind of picked their own chairs or own leads. Others, we picked it for them just because it just happened to fall in place that way. An example would be like our harm reduction folks. The chair to that was our harm reduction director there here in the county. It just was a natural fit to be able to put them in that place. But that of course has challenges, right? Because I will say, because we were so large, people moving around in their positions and their jobs, and the ebb and flow and that stuff is a lot of the challenges that we faced. Again, keeping people consistent in this subcommittees are on the task force. So.
Yeah, and I think one of the big challenges too is just that initial burst of energy and enthusiasm can sort of fizzle out if people don't feel like they're making some sort of forward progress. And so it sounds like the working groups is one way just to get more specific so they could get that, but also the reporting back in a way quarterly creates sort of a incentive, I guess, for the group to make that forward progress that they can report out. I mean, that's really